Welcome back. All right, so I am dying to introduce our next two presenters. We have Dr. Heather Cook, who is a palliative care clinical pharmacy specialist at MedStar Franklin Square Medical Center in Baltimore, who we have a bunch of preceptors from that group because they have their first residency here. I met them earlier. Yay. Heather graduated from University of Maryland School of Pharmacy with the geriatrics and palliative care pathway. She went on to complete a PGY1 pharmacy residency at MedStar Union Memorial Hospital, followed by a PGY2 in pain and palliative care here at the University of Maryland School of Pharmacy. Most recently, she also got her Master's of Science in Palliative Care degree from the University of Maryland, Baltimore, and obtained board certification as a geriatric pharmacist. Her clinical interests include inpatient and outpatient palliative care, geriatrics, telehealth, and new practitioner development. And next to her, we have Dr. Lynn McPherson, who is a professor at the School of Pharmacy and Executive Director of Graduate Studies in Palliative Care, which is the Doctor of Philosophy, Master of Science, and graduate certificates at the University of Maryland, Baltimore. She has maintained a practice in both hospice, locally and nationally, her entire career. Dr. McPherson is particularly interested in opioid conversion calculations, which I'm sure we've all benefited from her knowledge in that aspect, and the safe and effective use of medications in patients with a life-limiting illness, ranging from drug selection, deprescribing, and risk mitigation. And they're going to talk to us about, aren't you just dying to know how to care for dying patients?
Thank you, Dr. Barboni. So a quick story. When I was a young faculty member, I was like 12 years old. It was in my first semester, and right before I had started as faculty, a very well-known professor, Dr. Peter Lamy, who I know you've heard of, very well-known in geriatric pharmacotherapy, started a course called Elder Friend. And it was meant to go through all of pharmacy school. So it was like 1 credit each semester. And the first semester it was fine, like literally just go make friends with an old person and take a medication history. And then when I was hired, he said, you know what, I'm turning this over to you. I was like, oh, that's super cool. So I kind of upped it a little bit and I gave them each an assigned old person. So some of these old people were from my practice, which is hospice and palliative care. And I remember about a month in, we were having a class meeting because some of them were upset about the health status of some of these older people. And one young lady started literally crying in the middle of this class and said, how dare you assign me to a woman who has a terminal illness? I was like, well, girl, unless you get a job in the Department of Sunshine and Rainbows, you are going to run into people in your practice. I don't care where you are or what kind of practice you have, you're going to run into people with a terminal or at least a serious illness. So I was just talking to the people who are in charge of redesigning our curriculum. And I said, you know, this is a little tricky because it's sort of like diabetes. If you can teach diabetes, you can do the rest of the curriculum because they have every other disease there is. And palliative care, well, we kind of sort of are specialists, right, Sydney? Another one of my former residents. It's everything, but at the end of the road. And even on top of pharmacotherapy, there's a whole nother element, right? Take it away, Dr. Cook.
All right. So yeah, we're excited to be here with you talking about dying. We want to make sure that what you're taking away from this is kind of the clinical aspects, but also how do we support learners through the process? Because we know it can be quite emotional and overwhelming. All right. So just to get these knocked out, our objectives by the end of this session will identify factors that affect the patients and the family's beliefs and perceptions regarding end-of-life care. We'll develop skills for communication, support, and advocacy for patients and families during end-of-life care. We'll examine and implement evidence-based interventions to manage pain and discomfort at the end of life. We'll describe signs and symptoms of imminent death, and then acknowledge their own and other healthcare team members' feelings and responses. Lastly, we'll discuss resources for support and self-care. All right, up here you can see the proposed trajectories of dying. I think what this really comes down to when we're thinking about our own emotions, thinking about how someone does die, unexpected versus expected deaths do make a difference in how we kind of process those feelings. So just to kind of outline some different ways that, you know, people can decline and decompensate. So up at the top left, you'll see a sudden death. So an example of this could be someone who is seemingly healthy, either has a motor vehicle accident or an MI or something like that, and just kind of declines that way and very suddenly. The next in the top right, we have terminal illness. Oftentimes we'll think of, stage 4 pancreatic cancer, someone who was healthy and then all of a sudden has a new disease state that is quickly and rapidly leading to their decline. Bottom left, we have organ failure. An example of this could be someone who has congestive heart failure. They're kind of floating along. They're getting some diuretics at home. They keep getting volume overloaded, coming back and forth to the hospital, needing IV diuresis. Eventually leads to cardiorenal syndrome, ending up in the ICU and leading to their death. And then on the bottom right, we have frailty. So an example of this could be someone who's struggling with dementia, mild, moderate, severe, advanced dementia, and ultimately is becoming more disabled, bedbound, and needs more care. So as we're kind of thinking about our role as the pharmacist, it also helps us align our medication recommendations with what kind of trajectory that we see. For example, if we had someone, sorry.
It's okay.
If we had someone who was in the top right and someone who had sudden death, we'd expect to be following all the current guidelines for all aggressive, guideline-driven therapies. Whereas if we have someone with dementia in the bottom right, we would start thinking about where can we optimize medication regimens in line with patients' and families' goals of care. We would be thinking about deprescribing and pulling back medications that don't make sense anymore. So I think it's just important to understand overall what disease states kind of correlate to these trajectories, and that'll come with time and experience. Next, we have some factors that affect beliefs and perceptions about care. So every patient and family brings their own unique perspective to the table, especially when they're thinking about what their end-of-life care would look like or want to look like. We often say in the hospital, we're the experts in medicine, but you're the experts in you. I think we need to account for both cultural and religious considerations. So for example, those who practice Hinduism believe that every thought or good deed will lead to karma, which will then follow in the next life through reincarnation. And what's interesting is that in end of life for these patients, we notice that they're okay with physical pain and suffering because they believe that that will lead to better outcomes for their next life. So even if it's something that I would not necessarily choose and want to have that pain, I think it's important to recognize that there are other considerations outside of that we may not be completely aware of. Next, we have age. So when we're thinking about this, something we kind of consider in the hospital, aggressive versus non-aggressive interventions. A 40-year-old with, 2 young children may want full court press with their interventions, as opposed to someone who's maybe 90 years old, lives in a nursing home, is bedbound, and maybe would say, okay, I've lived my life. It's time for a comfort care approach. I also think that when we're thinking from like a learner's perspective and handling those emotions, it feels a lot different taking care of a patient who's maybe 30 years old with cancer than it is to be taking care of someone who's 90 with advanced dementia. And it's just, it is more taxing, and we have to definitely reflect on those emotions, which we'll kind of get into a little bit more. And then lastly, on the slide for past experience, everyone has different experiences for end of life care. Some people have seen death in their family and others haven't, and they may be a completely neutral slate or state to that. We often hear in the hospital, my mom signed up for hospice and the morphine drip killed her, or, hospice is there to hasten someone's death. And we often have to come in and provide re-education to say, well, that's not really the intent or the goal of hospice. Let's talk about what you're worried about and where those concerns are coming from, and really get to kind of the core of what, how we can best serve the patients and come to a mutual plan. We often need to meet patients where they're at. We need to make sure patients are having informed consent for all available treatment options and not providing our own bias as the medical team. I think it's important from the learner's perspective to have the reflection for really heavy consults where we're seeing really distressing symptoms or distressing cases. And I think as a preceptor, we should be kind of engaging our residents and saying, you know, that felt really heavy or that was really sad. Like asking those open-ended questions, like, how are you feeling or what are you feeling about that case? Because it may bring up things from their past that they're willing to share or not willing to share. But I think it allows opportunity to debrief and make sure that you're showing empathy and consideration for your resident and just making sure that you're doing those check-ins. So in terms of how are we making sure that we're respecting patients' wishes, one way to do that is through advanced directives. Advanced directives, we'll get into it a little bit more, but it's essentially a structured way for us as a medical team to help make sure patients are expressing what their wishes are and what their medical preferences for end-of-life care are. As a side note, everyone should have one. Every single person in this room should have one. If you haven't done one, you can go to mydirectives.com and fill one out. I think the most important thing is just to make sure you have someone listed as a healthcare agent and someone who knows what you would want in different scenarios, which we can talk about. Essentially, it's used to appoint a healthcare agent. It's used to make wishes known in the case of end-stage terminal or persistent vegetative conditions. Ideally, everyone in the hospital is asked if they have an advance directive. You know, if it makes its way into the chart, that's good. Otherwise, don't be afraid to ask family members or patients if they wouldn't mind bringing it in, so that we as a medical team can make sure we're honoring those wishes. There are 3 parts to an advance directive. The first is the healthcare agent, or a medical power of attorney is often synonymous for that term. Part 2 is treatment preferences, and this is where people can fill out different options, as well as write in if they have any specific treatment preferences that they have. For example, some people may say, you know, I'm okay with artificial nutrition, give me a feeding tube. Some people would say, I never want dialysis. I don't care if I'm going to die. Don't hook me up to that machine. So it's just a way for people to kind of demonstrate in writing what they would hope for with their care. And then there's an after my death section, which is also optional. So I think one way to help validate learners' feelings regards to making sure that we're providing the best care possible is to make sure that we're kind of reflecting on whether the treatment that we're providing in the hospital reflects what the type of care that they're receiving, and it's correlating with the advanced directive. Some people say, you know, I want to fight till my very last day, and that's great. And if someone ends up in the ICU and the ED and we end up doing a code for them and they die in the process, you know, it makes me feel a little bit better, sleep better at night, knowing, you know, that's okay. Like that's what they would have chosen. Similarly, if someone's saying, if I'm in one of those 3 conditions, if I'm in a persistent vegetative state and I want comfort care in that scenario, and we make a hospice referral and we start a comfort care order set, we can also feel good about knowing that that's how we treated those patients at end of life. If there is a scenario where the 2 are not necessarily jiving, that's when I think it's a good idea to consult palliative care or the ethics team, just to make sure that we're getting an additional layer of either support or perspective, and we can kind of help bring together more of a mutual plan. Oftentimes, there's a lot of movement that can be made by bringing together all the specialists that are involved in patients' care. So cardiologists or GI, the ICU team, we often see that they're all kind of working in silos. They put in their notes for the day and then, you know, follow up tomorrow. And patients and families are left kind of thinking, you know, what is the opinion here? What should we be doing? They're not all talking with each other. I think it's important just to be able to call those family meetings just so everyone's on the same page and aligned with next steps. All right, communication. So it's important to know your own attitudes and emotions and biases about death, and to also know what your limitations are. You know, if you just had a grandfather who just died of, you know, a heart failure, fluid overload in the ICU, then maybe, you know, you take a little bit of more distance or take a step back from seeing that patient one-on-one. just be aware of kind of like your own inherent limitations. The next is assess patient preferences for hearing information. We'll often ask, are you someone who likes all the details, or are you someone who instead just wants the big picture? You'd be surprised that a lot of patients do and don't want to know their prognosis based on available literature, especially in cancer. Some people will say, I don't want to know how long I have. That'll cause me way too much anxiety. And other people are like, oh, if you could tell me, then that would be more meaningful to me so that I know, in the next 2 months, I need to really wrap things up and make sure my family has everything they need. Along those lines, give honest and accurate information filled with empathy and understanding. Next is communicate assessment findings to the family medical team on an ongoing basis. I think as a pharmacist, don't be afraid to advocate for the patient. If you're hearing that, you happen to go into the room and doing a med rec and you're hearing that they're really worried about something or there's misinformation and they don't have a clear picture of what's going on, feel free to advocate for them and talk to the medical teams, because it's nice as a non-provider to be able to kind of step into that role and build that rapport with those patients and families. Next is evaluate the patient and family's comprehension of what's occurring and provide information on education where is needed. Along those lines, as a non-provider, I often attend family meetings in the ICU and other units. And within those meetings, I sometimes ask questions that I may already know the answer to kind of help facilitate the family's understanding. Because even if there's a question that I maybe don't know the answer to, I know if I don't know the answer, then the family's definitely not tracking what's going on. So you can sometimes use that as a tool to make sure that among the medical team, we're making sure we're giving as clear information and not getting all jumbled up with the medical jargon, because that can also be very overwhelming for family. So oftentimes we use common phrases in the medical team that they may be very well intended, but are not always received as well as they're intended. I'd encourage you as we go through these to kind of think about, have you heard these before? And let's reframe them. So the first common phrase is, so, you understand what's going on with your loved one. And instead you can say, tell me, what's your understanding of their condition? It's much more open-ended and more positive. We're recommending withdrawing care. That's a very negative connotation. So instead we could say, we're going to continue to care for your loved one and focus on their comfort. Next is, your mom is really suffering. You could say, do you think your mom is suffering? And that can open up and lead to further conversation and coming up with a better plan. The next is, I know how you are feeling. Again, very well intended, but you're not the one in their shoes. So just be aware of that, because they could very easily come back at you and say, oh, no, you don't, which has happened before. So instead, we could maybe say, I'm sure this must be really difficult for you, or I can imagine that this is really difficult. The next is, oftentimes when we're talking about hospice, you would be giving up. Instead, we often say you would be fighting for your comfort. Instead of fighting the cancer, you're fighting for your comfort. Next, we would change your code status to do not resuscitate. And instead, we often say in hospice and palliative care, we would allow you to pass with peace and dignity at the end of life. Here we just have some barriers to communication, lack of experience, fear of one's own mortality, disagreements with decisions, not understanding the cultural or spiritual beliefs, ethical concerns, personal experiences with death and dying, and then time. As we talked about, just be aware of your own limitations. I think something to really think about in every practice setting, every subspecialty, oncology, transplant, cardiology, whatever it may be, you only have one shot at making someone's death a good one. There's no do-over. So if there is something you can do to optimize medications or support the patient or family, I think at the end of every day, it's always worth it, because you get one chance. And with that in mind, we should always kind of bring to the forefront, why did we get into this field and why do we want to help people? I I think there's a lot of power in being a pharmacist and knowing the medications, which, Dr. McPherson's going to talk about a little bit later, but we have a lot of power and we can certainly influence how someone dies. So then that leads to what is my role as the pharmacist? Again, there are different settings that residents will be practicing in, and oftentimes those settings can kind of are very different from like a palliative care setting. In the ICU and the ED, full court press, you're there to save someone, and it's kind of the default that you would want to be doing everything possible trying to resuscitate them. And sometimes we have to think about, well, like, what does that resuscitation look like? Is that something that the patient would expect for us to be doing? So just something to kind of keep in mind. As I've kind of alluded to, we should be a human being first and a pharmacist second. Oftentimes, just going in to meet with the patient can be all that they need, just kind of throwing your agenda out the window. And if they say, I'm actually worried about these 3 things, well, then that's the perfect opportunity to bring that back to the medical team. Even if you ever feel stuck, that's okay to say, hey, I'm a pharmacist. I'm not quite sure what to do here. Let me go talk to the medical team and I'll certainly get those things clarified for you. It's important to meet the patient where they're at, and sometimes that means throwing out our agendas. So next we can, of course, support patients physically, especially with pain and symptom management at the end of life, which we'll go over in a few slides. And then social, psychological, spiritual, and advocacy. At the end of every visit, I like to ask, is there anything I can get you? Is there anything I can relate to the nurse? Do you need a dose of pain medication? Just making it just a little bit easier to be a patient in the hospital that day, because it's certainly not easy. There's a lot going on. They're getting new medical information. They're definitely not sleeping, and they definitely don't like the food. So, if you can help them in just a little bit of a way and take that extra step, it certainly goes a long way. I also challenge learners that if you're in a setting where you're in a family meeting and there's silence because patients or families are kind of processing that information, I know our kind of like prerogative is to like say like, oh, okay, like we need to get to the next topic, or, we need to fill this space because the patient's getting upset. But I challenge you just to like sit in that silence and let the patient really understand what's going on, because oftentimes in that silence, patients will then tell you what's actually on their mind, and you'll help them navigate into what are they truly worried about at the core, and how can we as a medical team support that. So don't be afraid of silence. Don't be afraid of tears. I remember feeling really guilty when we would make patients and families cry at the beginning of my job. And now I've kind of reframed that instead as, you've broken through to them. You've really gotten them to open up, and that's not always possible. So when it does happen, it's okay. And they're going through a lot. And just, again, you can sit with them. Feel free to stay quiet, or you can say, okay, if you're feeling uncomfortable, you could say, I'm going to step out. I'm going to go get you tissues and a drink. I'll be back in a few minutes. So just a piece of advice there, because it's common in the hospital. All right. So another thing to think about is part of the, I guess, anxiety around death and dying is not knowing what to expect when someone is actively transitioning. So something to consider, here are just some of the signs and symptoms that if you're noticing these things, it may mean that death is coming closer. So progressive weakness, a bedbound state, changes in mental status, whether that's lethargy, excessive sleeping, confusion, decreased intake of foods and fluids, dysphagia, so trouble swallowing, delirium. It can be hypoactive, hyperactive, or mixed. Changes in respiration, so that's respiratory rate or the type or pattern of their breathing. Also, something is known as the death rattle. So it's essentially the secretions start to pool in the back of their throat and they can't swallow the secretions. It can be alarming to hear, but it's typically not bothersome to the patient. And then we'll use some Levsin to kind of help dry that up. Next, we have cooler extremities and modeling, and then decrease or cessation of urine output. So again, these are just signs to kind of look out for. Hopefully knowing this would make you feel a little more comfortable with knowing things are moving faster than we expected. And just so you can be aware of what's going on. Every person has a different idea of what they consider a good death. Some people are okay with dying in the hospital. Some people are okay with dying at home. I think it's important to ask patients if you have the opportunity to do so and they say, I'm afraid of dying. You can say, are you afraid of the dying process and the suffering that may come along with it? Or are you afraid of what comes after? Because the way we treat those are quite different. The first, if they're afraid of the dying process and suffering, as a pharmacist, we have a lot of control over that with the medications. If it's more about what comes after, that's more of that spiritual or religious concerns where it's a little bit of a different avenue. You know, we'd be calling the chaplain or their own, home church folk or whatever. So I think it's just important to ask that question because if it's the first, we definitely have ways to treat that.
Alrighty, so we're going to talk about some symptoms and how we would manage them in a serious illness. As Heather just said, some people are very fearful of the dying process because they're terrified they're going to die in pain. And talk about life experiences influencing what's going to come. And your opinion of that is if you're a woman diagnosed with stage 4 breast cancer and 3 women in your family died a horrible death with breast cancer, you are pretty much convinced that you also are going to have a horrible, painful death. So there are many, many symptoms. That's what I meant by you're kind of an expert at the end of the road in a little bit of everything. So looking at pain, as Heather just alluded to, it's not just the physical. I know that I'm a big fan of transdisciplinary care, which is, I think we should all be cross-trained a little bit. I like to say that I'm not happy unless everybody around me goes home as 10% pharmacist. So I swear to you, I'm 10% social worker. So the question I like to ask patients is, what's one thing I can do for you right now? And I might be thinking, oh my God, they're going to want more Dilaudid or whatever. And it could be, could you go get me a glass of water? Oh, sure. That wasn't on my radar, but sure, I can do that. But there's the physical domain, certainly, but social, psychological, and spiritual. So this is the model known as total pain. It was popularized by Dame Cicely Saunders from the United Kingdom, who really is the mother of the modern hospice movement. So when you look at the drugs that we have, I mean, none of the pains that we see are one size fits all. I am an enormous fan of doing a multidimensional assessment of any symptom. So there are several tools that are available. I just like using the PQRSTU model, precipitating, palliating, previous treatment, quality, region radiation, severity, temporal, and how does the symptom, notably the pain, affect you? And when you're going through that, there are a couple of purposes here. It allows you to get a pretty good handle on what's the pathogenesis of this pain. What is causing this? Is it nociceptive? And if it is it somatic or visceral? Or is it neuropathic? Or is it all the above? Because pain is not one size fits all. For example, neuropathic pain will not respond to a non-opioid analgesic. Unfortunately, most neuropathic pain in this country is treated by PCPs who love to give them Tylenol or a non-steroidal. You may as well give them Chiclets or Skittles. It's still not going to help, but it's a lot more fun. Opioids are only partially effective in neuropathic pain or metastatic bone pain. So you really have to look beyond that. But lots of drugs to pick from. I think people often forget to use the adjuvant drugs, like the gabapentinoids. I personally prefer pregabalin for a lot of different reasons. I love looking at comorbid conditions. And if someone has depression and neuropathic pain, don't even look at the SSRIs. It's going to be an SNRI probably, and you probably wouldn't want to use a TCA either. So, I mean, this could literally be a 3-credit course just on this slide. When you look at dyspnea, what is dyspnea? Everybody thinks it's shortness of breath. And yes, it certainly is shortness of breath, but really it's an uncomfortable awareness of breathing. So people will describe it as the air doesn't go all the way down, or it's harder to breathe in than out, or the other way around, and they will use words like, I feel like I'm drowning. I feel like I'm suffocating. Am I going to suffocate to death? And thankfully, that rarely happens. But if it does look like somebody is going to suffocate to death, the good news is my mother-in-law died of lung cancer. And she said to the doctor, how am I going to die? What's it going to feel like? And he said, well, you'll kind of just brown out basically, and you'll just kind of fade away. And she was comforted by that. But if it does look like somebody is kind of, suffocation is a big part of their end game, then we talk about something called palliative sedation, which is a spectrum. It's not a yes, no. We don't just completely knock people out on a whim. But what do we do for that? Well, positioning is very important, sitting up a little bit. People with COPD use that tripod position, pursed lip breathing. The best thing you can do non-pharmacologically is a fan in your face. Very powerful. Stop the things that are making it worse, like the families, God bless them. The one thing when my father was dying, my mother could do best is she was an amazing cook, and she really tried hard to force feed him. And I was like, this is not a good look. We shouldn't do that. This is part of the normal dying process where you're not as interested in eating and drinking as you approach the finish line. But when people insist on doing that, or artificial feeding and hydration, people literally do kind of start to drown. With the enteral feeds, you get residuals that are like as big as what went in. So that makes the dyspnea quite a bit worse. We use oxygen, interestingly, is not particularly helpful unless they're hypoxic. But who among us has the chops to say, I am really sorry you're sucking wind, but no oxygen for you, cupcake? We don't do that, obviously. Probably one of the best things to use is an opioid. We don't even quite know how opioids work to treat dyspnea, but very effective. Morphine is probably the most data. My girl methadone, my favorite drug in the universe, is not particularly effective professionally, not personally. The benzos are only effective, but it really is anxiety driven. So if it's not due to anxiety, all you're really doing is sedating them. Again, not one drug to fit all symptoms here. I think nausea and vomiting is more complicated than pain. And I think whether it's dyspnea or nausea or constipation or anxiety or pain, you should do that multidimensional assessment. So if somebody tells you, oh my gosh, if I stand up quickly, the whole room spins and I want to vomit, that's vestibular. So we would probably look at a drug like meclizine or a different antihistamine, for example, maybe scopolamine. But then you have to balance that with this patient is 84 years old, and scopolamine is one of the strongest anticholinergic drugs in the universe. So if you can't just say to an anticholinergic drug, okay, what I need you to do is go fix the nausea, but don't give them dry mouth and blurred vision and constipation and urinary retention. You're going to get the whole boat. So you have to be very careful in selecting those. Nausea can be due to constipation. Not only constipation, but if you are literally FOS, full of stool, I know what you were thinking. I know what you were thinking. But if you're full of stool, that's called obstipation, where you literally, people have died from aspirating fecal content. Not a good way to go. That is not a good death. Sometimes people will be so impacted with stool that fecal content will ooze around it, and they think, oh my gosh, I have diarrhea. Let's go get the Imodium. Oh, girl, you don't want to do that. But that can cause major, major nausea. Dysmotility, where things just are not moving along. So we might think about metoclopramide. And then most of the nausea we see in end-of-life care is due to stimulating the chemoreceptor trigger zone, which in turn stimulates the vomiting center. And opioids are classic for causing that. Constipation. My friends call me the poop queen because I love to talk about constipation. I say I am a PhD prepared constipatologist because I love talking about constipation. So too much stool, too little stool is problematic. Fiber may help, but in our patients at end of life, they're probably going to be on an opioid, and giving them fiber, what do you think? Good idea? Not a good idea? It's not a good idea, because then they're really going to get impacted. So for example, if someone has opioid-induced constipation, give them Metamucil, cover your eyes because they might explode. Not a good idea. Our patients are frequently dehydrated. It's actually more comfortable to die on the dry side than the wet side, if you know what I mean. Motility. Our patients often are bedbound. I mean, and you'll know you have an inexperienced lecturer when they say to you, now the way we treat constipation is fiber and activity. I'm sorry, the patient's going to die in 3 days. You really want him to take a walk around the block and eat 3 bran muffins? That's just not reasonable. So you have to be realistic here. I would say our workhorse drugs, because it's generally opioid induced, are going to be senna, which is a stimulant, and polyethylene glycol, which of course is an osmotic, draws fluid into the bowel. But that brings up another point. Are they really dehydrated? Do they have fluid in the body they can draw into the bowel? Can they choke down 4 to 8 ounces of fluid? Maybe they can't even do that. But senna comes in a lot of different dosage formulations. We have tablets, capsules. We have a senna tea that you can make. My favorite, and I should put this in my living will, is senna sprinkles. It looks like Jimmy's on ice cream. How awesome is that? And there are rectal formulations, of course, notably bisacodyl. Lubrication, I think rectal suppositories certainly are one way to go, like a glycerin. Personally, I think the digital manipulation is what is stimulating the bowel movement there. Mineral oil, I don't know, I'd be careful. I wouldn't do that habitually because people can aspirate it and now they have lipoid pneumonia. Docusate is not your friend. Everybody thinks Docusate is the berries, but particularly with opioid-induced, Senna plus Docusate does not work nearly as well as plain Senna. So the Docusate just kind of gets in there and messes everything up. So just go with plain old Senna. That's the way to go. And always be mindful of medications that you can stop. So we just talked about the anticholinergics, famous for causing constipation. I'm a big fan of deprescribing. I probably spend more time recommending stopping drugs than starting drugs, which is pretty ironic for a pharmacist. Delirium, oh my gosh, this is the bane of our existence here, particularly with somebody who has dementia. People call it terminal restlessness. There are a lot of different names for it. There's delirium, which is more of a cognitive thing, and then there's agitated delirium, or yeah, they've got the cognition going on there, but if they have hyperactive delirium, where they're trying to like throat punch the nurse, which is never a good look, that's a whole different kettle of fish than somebody who has hypoactive delirium. What is that? That is somebody who is quietly confused. They are not mover, shaker, troublemakers. They're lying in bed, confused as all get out. But if they're in a nursing home, nobody even thought to ask them, hey, are you in there? Are you confused? And that's actually more prevalent than the hyperactive delirium. So you can imagine the hyperactive gets all the attention because they are trying to escape the bed, beat people up. And it's interesting where you get a little old lady who's dying and now is delirious and now is cursing like a sailor. It's like, whoa, where did that come from, Grandma? So it's really interesting how people manifest this at the end of life. The whole issue with delirium is it's very acute onset, and it's like flipping a switch. They can be right as rain, you flip the switch and off we go to the races. And it can fluctuate, come and go during the day. And people can flip from hypoactive to hyperactive multiple times during the day. The treatment, well, here's the problem. We do use antipsychotics to treat delirium, but if you look at the data, people who have dementia and delirium, using an antipsychotic increases the risk of sudden death. So now all the bean counters get very upset about using an antipsychotic in that situation. So we definitely want to try to maximize our non-pharmacologic interventions. And that can be difficult though. It could be a patient in a nursing home who literally needs somebody to sit with them 24/7. The nursing home's not going to pay for that. The family's going to become exhausted. How do you guys handle that in the hospital?
We do have sitters in the hospital, but that is a barrier to discharge because if they want to go to subacute
Right.
rehab, they can't have a sitter in the room for, I think it's 48 hours. So, and they can't of course be like spitting and kicking and punching people.
Yeah.
So
when the rubber meets the road and we will use an antipsychotic drug. Sometimes we'll use valproic acid instead as a first stop. Haldol is a very dirty word in palliative care. People don't like to use it. People feel a little more comfortable with the second generation. So we'll use risperidol and Seroquel. I'm a big fan of olanzapine. I think we should just go ahead and put it in public water. It's a beautiful thing for nausea. We could all use a little hit, in my opinion. But that's just me. I know I work with a very large hospice and they had taken care of this little old lady forever and ever. So they had been paid a lot of money by Medicare. And after her death, the family complained that at one point she was in the ER and that she was in our unit. And we did give her a baby low dose of Haldol. And she was quite combative, trying to beat people up. And the family complained and Medicare said, we want all our money back because it was inappropriate. So administration asked me to review the case and write a letter. So I wrote a letter and I said, you're really wrong here because she literally was suffering with that delirium that she was experiencing, and 0.5 milligrams of Haldol calmed her down. You've got the note from the nurse saying she was looking much more peaceful. And frankly, I think when we can finally control a troubling symptom like pain or like nausea or delirium, and we can control it, people relax enough to die. So it was a kindness to give that woman, and we won the case. So there you go. Nana, nana, boo, boo, Medicare. Anxiety, you know, if I gave you all the GAD questionnaire right now, every one of you would say, yeah, I've had anxiety in my life. Absolutely. Whether it's the 1 question, the 2, the 7, or the 9, I promise you, you would hit positive. So this is very, very common. So this is why we're a team. We get the psychosocial people in there. Why are you anxious? What are you worried about? It could be, I've had patients tell me, I have been a naughty kitten all my life, and I'm afraid when I die, I'm going to hell, and I'm going to roast in the eternal fires of hell. Well, Ativan's not going to fix that. So where's the priest or the chaplain or whatever? So this is why we're a team. There's a lot of existential distress. One of our PH candidates I was just talking to today in palliative care, only one in the country, but hey, what do I know? She's investigating the use of psychedelics in people who have this existential distress. And I think that's very exciting. Psilocybin and MDMA, very exciting, the possibilities there. But people can be anxious because they're in pain or they're terrified about this dyspnea, or again, the fear of death, or what's going to happen to my family when I die. It's still not uncommon to see a man dying, usually elderly at this point, who says, my wife has never written a check in her life. What is she going to do? So the social worker teaches her how to write a check. So we really have to get down and dirty like that. So a lot of non-pharm things that we can do, but we do end up using benzos. And you know, what's interesting is a lot of people who are anxious are also depressed. The good news is what we see is 90% of anxious people are depressed and 90% of depressed people are anxious. And the SSRIs work equally as well for both. And the anti-anxiety effect is going to kick in more quickly than the antidepressant effect. If they were depressed and close to the end, and they didn't have heart problems, we would use methylphenidate because that works in the next day or 2. Back to you, Dr. Cook.
So kind of to piggyback off that, so where does spirituality fit in? Of course, spirituality is the personal belief that influences an individual's assessment of meaning and relationship with things larger than one's own understanding. Again, I agree. Anxiety is often stemmed from that existential distress. You know, it overlaps with spirituality and religion. And as pharmacists, we may not be as comfortable addressing that. And I agree. That's when we call in our social workers or chaplains to kind of help figure that out. But it does this, you know, spiritual assessment and taking care of patients. It affects a patient's sense of wholeness. The team can openly acknowledge their faith system, and it leads to a clear understanding of patients, their treatment decisions, as well as their awareness of their educational needs. So there really is no standard definition of how to support someone through spiritual care, except it's agreed that prayer is certainly part of that. You know, often patients will ask us in the hospital, you know, can you pray for me, or can you pray with me? And if you're comfortable doing that, by all means, step into that role, because that's what the patient needs in that moment. If you're not comfortable with that, sometimes you can say, why don't we pray silently together and I hold your hand? So it's a way to kind of support them without being fully vulnerable. I think it's also important to kind of note here at the end of life, and I'm sure you've heard this, when patients are making that active transition process to death, they'll see either hallucinations or they'll see the people in the room, the people who have passed, and are kind of welcoming them into the next chapter. It's not usually distressing. It's usually comforting, and we don't treat medications or treat that with medications. But if you find that you walk into a room and someone may be hallucinating someone who's not there, that's something that could be, and to not be alarmed by that necessarily. So ultimately, we should be present and try to support the patient through that process, try to provide a comforting presence, and, you know, provide education where needed to the family. In terms of just a few special considerations, life-sustaining and prolonging therapies, often in the ICU, we will see that families choose to withdraw life-sustaining treatments in order to reduce suffering. We'll be looking at that advanced directive and saying, you know, things aren't really congruent or jiving with what this patient would want. So it's very common we are withdrawing ventilators, artificial nutrition, or hydration, deactivation of ASCDs, antibiotics, or chemotherapy. If you are doing a compassionate extubation, be aware that many facilities have different order sets that you can fall back on. So at MedStar, we have our typical comfort care order set, and then we have a compassionate or compassionate extubation order set as well. And it helps kind of align the medications with what you're worried about in terms of symptoms. Sometimes when we're doing compassionate extubations, it's pretty expected based on ventilator settings if someone's going to pass really quickly, or the attending may say, they might hold their own for a little bit and it may be hours to days. Then we can kind of adjust the medications to make sure that the patients are comfortable from both an anxiety and a dyspnea perspective. Again, this can be emotionally and ethically challenging for patients, families, and nurses. We really need to make sure patients and families are informed of what this would look like for risk versus benefit. And then we'll sometimes get the request for physician-assisted suicide, where essentially a physician can provide a medication to help end someone's life. And the patient has to be the one to take the medication. So if it's someone who doesn't have manual dexterity to be able to do that, they're not a great candidate for it. This is not legal in Maryland. So if you get that question, sorry, go move to DC. Can't do it here. But it kind of comes back to, what is the patient worried about in terms of suffering? We can't hasten someone's death with medications, but we can optimize the medications to try to treat any type of physical suffering or symptoms that they may be experiencing. And just a kind of final note, end of life care is very heavy. It's a hard topic. A lot of people go into medicine to try to save people. And when that's not always the outcome, it can be very disheartening. So it's just important, especially during your residency where you have so many things going on, so many projects, and you're just feeling overwhelmed, to make sure you're doing something for yourself, even if it's just 5 minutes a day. Of course you hear of like exercise or, listen to music or go take a walk, just something to decompress. If you have a co-resident, it's always helpful to kind of talk about what your experience has been and what you're struggling with, if you trust and feel open to that. You can always kind of debrief with a preceptor. It's just helpful to have other people who kind of know what you're going through. Oftentimes, I would tell my family early on, like, oh my gosh, I saw this patient today, and they would not know how to respond if it was like a really morbid, like death. They would just kind of stare at me, and I'm like, okay, we're not going to be doing this anymore because this is just sad. So, try to lean on the support systems where you feel comfortable. Dealing with feelings of guilt. Again, we go into this field to try to save people. At the end of the day, people will end up dying regardless of our interventions. It's important to recognize that the disease state that they have is what is ultimately leading to a patient's death. It's not something that you could or couldn't have done. And then here at University of Maryland, there are wellness resources through the EAP office, so they can provide confidential emotional support, financial resources, work and academic life solutions. So here's the website, here's the link if you feel inclined. Just know that support's available through university.
Well, before we get to this, are there any questions for either of us? Everybody's awake. That's a very good sign. Yes.
I have a quick question about something that was mentioned like earlier on in the presentation in terms of using like rephrasing your language. I'm sure that patients get actual documentation about what they're signing on for, but do you find that in rephrasing it, sometimes patients get lost in what you're trying to say? Like especially regarding DNR, if you're not outright explaining what it is, do you ever feel like some people don't fully comprehend what you're saying?
We always want to make sure patients are being informed of the risk versus benefits of every intervention. So we will have the conversation very explicitly. Many times, especially when it comes to code status, people think, all you have to do is just kind of lightly tap on someone's chest a few times. They're magically going to spring up and wide awake, pop open. No need for intubation. So it's important to outline what an actual code looks like, because the general public minimizes what that is like. It's very traumatic. You're breaking ribs. You're doing very deep compressions. if you can't, if oxygen is an issue, you need to have intubation. It's funny when people say, oh, do CPR, but not intubation. Like that's not a thing. So we have to make sure very explicitly that they are educated. And then when they start talking about, well, actually that doesn't sound great to me. Well, then what is the other option? Then we would say, you know, if your heart were to stop here in the hospital, we would allow you to pass with peace and dignity at the end of life, especially knowing that in your given condition, your advanced condition, CPR is not going to bring you back, or if it does bring you back, you're going to be even further debilitated in the ICU. And who knows if you're going to be able to come off a ventilator. And if you can't, then your family has to make the decision to either leave you there in a vegetative state or, you know, withdraw that care, which can lead to a lot of guilt as well for family, especially if they didn't know what the patient may want. So we do absolutely describe in detail what that would look like.
So here are some resources. The first is the Center to Advance Palliative Care. If you have a umaryland.edu email, you can access this resource by using your work email. We use it for our graduate studies program, but they have wonderful education on the website. Most hospitals have a subscription too. Vital Talk is all about how to have these conversations. The American Academy of Family Physicians, I like the American Academy of Hospice and Palliative Medicine. And the Fast Facts is wonderful. They've got an app and you can go to their website. It's like a 2 to 3 minute read on like 400 different topics that have to do with end of life care. And my shameless plea for what I do for a living is our graduate studies in palliative care. We offer 7 graduate certificates, which is 4 courses. We have a Master of Science degree, and then we do have a Doctor of Philosophy degree, which is extremely popular. But the good news is if you are paid by the School of Pharmacy, you get tuition and admission and you don't have to pay anything to do this. So that offer is out there for anyone paid by the school to at least earn the first graduate certificate, 2 courses in the fall, 2 in the spring. And Heather can tell you what it's like. Probably the last 5 years of our residents have done that. And pretty much all of them, after they have finished the residency, go on and finish the master's degree at some point because they have a few years to do that. Sorry if you're not paid by the school. I'd still love to have you, but you're going to have to pony up. So any last questions for us? Oh, anybody online have a question?
In the chat, it was asking, well, and it was to me, but do you have services for pediatric patients, or are your services for adult palliative care patients only?
That's interesting. It depends on your practice. I know that in my hospice practice, my whole career, we don't often have children. There are, like Children's National Hospital in DC, they have an enormous palliative care team. Do you hit kids once in a while, once in a blue moon? Not at all. Most people don't do children, but we just developed a certificate on pediatric palliative care because that is a really growing group right now. And I don't know as much as Dr. Parboni, but I know that children are, it's more than just their short adults, right? Am I right on that one? Yeah. Okay. Any other questions online? Well, thanks so much for paying attention. We appreciate it.